Well, good morning. And I just hope that the organizers of Global Health Innovations Conference gets the message that global mental health next year should be in the big house, right? We're overflowing into the hallways, and we got people lining the walls. And I really want to take off on that point. Global mental health as a field has just really escalated in the last couple of years. Really in recent memory, there's been in the meetings I go to and the circles I travel in, really a transformation of attention and visibility of global mental health and the global health agenda, what governments are thinking about, what organizations are thinking about, and what apparently a lot of you are thinking about. But I think we're at a really important point where the field, as it is emerging, the community of practice emerging around global mental health, really has to transition out of a mindset that I would characterize as really focusing on proving the case, making the case that mental health is important, and moving into lobbying for the blueprint and having the blueprint, the 5 things that have to be done in the next 5 years, the key capabilities that every healthcare system needs to have if it's going to provide mental health care, the targets, the metrics, the key skill sets. We have to have the working parts pretty clearly laid out, and we have to move into that gear, and I think we should do it with some purpose and urgency, and I hope what I have to say contributes to thinking about that. Other areas, HIV, the 3x5 idea, the 1 million bed net idea, the idea of actionable, numerical, galvanizing targets is what led me to this idea of reaching 1 billion minds and lives as an organizing target for global mental health. 1 billion being a not unfair characterization of the treatment gaps in the world today around these disorders. If you think about lifetime prevalence estimates for common disorders and what we know about treatment gaps, which in some countries are 90+%, then the odds of folks not getting evidence-based care who in their lifetime will have a common mental disorder is on that order of magnitude of 1 billion. Some might even argue that that's a lowballing. And that kind of a target, like 3x5, brings along with it attention and alignment of energy to really focus on the things that are highlighted in that kind of a target, which are not as much of the things we focus on, clinical things, treatment things. They're really things like engineering and systems design and metrics and information management. And quality improvement, which I'm going to talk about. And we really have to become literate if we're going to move a global mental health agenda along in those sorts of tools and work with those kinds of folks. If we're going to have a reach target to reach 1 billion minds and lives. And I'm going to offer sort of 3 general categories of thinking that can help innovate us in that direction. Paying attention to design, paying attention to how we use and think how the healthcare system generates knowledge, and then this idea that I'll close with, if I have enough time, because I always talk longer than I'm supposed to, of mental capital. This is data that I think a lot of you are familiar with. This is the last run of the global burden of disease data that appeared in the Lancet in December. Have people seen that? Are people familiar with this? You've got to check out December 2012 Lancet. So this is the latest data on the burden of disease on the planet that we live in. The colors are the relative contribution of different disease groups to the global burden of years of life lost to disability. As males and females, I forget which is on the left or the right, from birth to 80+ years, this is the distribution of the contribution of these diseases to years of life lost to disability. The take-home message is the red are common mental disorders. So it's not credible to have a healthcare system anymore that doesn't take on these disorders fully, given the huge contribution they have to being out of work, towards mucking up other healthcare, towards the actual impairing, disabling effect of disease on the population. And that's really a challenge up front of any characterization of key design features of mental health care and mental health care that can reach 1 billion minds and lives, is it has to take the mental health care challenge in those full dimensions, that disability dimension, not just treating cases, but the impact of those cases on social outcomes and things that we care about. We have a lot of literature that tells us that these kind of conditions and these related sorts of distress are both fuel and are fueled by all the sorts of social outcomes that we care about. Early childhood success, community safety, community violence, education success, economic performance, family integrity, and health. One of the greatest barriers to health is not attending to mental health. So it worsens the morbidity and course of all other medical illnesses. So if we're going to think about design, we're going to talk about reaching a billion minds and lives, we have to have it in mind we have to keep in mind a design that is up to the task of not only reaching in breadth, but reaching in the depth to which mental health affects social and human capital. And so we have to really reimagine how mental health care happens, and so to live up to where mental health care happens. I'm based in New York City, although I get to travel a bit in my interest in global mental health. But my interest in global mental health started with trying to solve problems in New York City. So this is a map of the density of the population who are on parole, who have left prison or jail. And I was looking at this map and I realized, you know, a map would look just like this. That was a map of high school dropout rates, or HIV infection rates, or single-headed household rates, or poverty rates, uninsured rates, gun homicide rates, and also probably depression rates and PTSD rates, and certainly substance use and addiction rates. And the point is that any design of an approach to reach a billion minds and lives has to be able to live up to trying to attack and unravel those tangled features, and to really reach not only, as I said, broadly, but also deeply. And to do that, we have to start over in how we're thinking about design. And so I was thinking, New York, how can our hospitals actually reach and be relevant to these problems? Because that map also looked uncannily like the catchment area map of the New York City public hospital system. And so I'm thinking, we're sitting on, literally, this complex web of ways that mental health matters, and how are we reaching it? And we're certainly going to have to reach it differently than we have been. This is a study that interviewed households in the US to diagnose retrospective 12-month likelihood of having a diagnosis of a common mental disorder in the prior 12 months. And then it asked people if they got care for that disorder. About 40% got care, a minority, and only a third of those got what sounded like minimally evidence-based care. So this is the United States with 50,000 psychiatrists. I often talk in other places, they say, well, how are we going to do this? We have one psychiatrist for 70 million people. And I say, well, I have 50,000 psychiatrists, and a fraction of the population can get evidence-based care. So whatever we're doing that isn't working, we shouldn't just do more of. And think it's going to work. So we have to really, so I was sitting in New York thinking about it, so we really have to rethink design to live up to the complexity and the importance of common mental disorders and where they live. And, you know, so I was thinking, well, how do we getting mental health care to be as easy as getting a flu shot? To get it when you want it, around the corner, in a place you're comfortable with? What do we have to think differently about design? And that's how I got attracted to things going on in other parts of the world, because they were really thinking about that. Resource constraints required thinking about how do we scale down complex technology so it can be easily managed in low resource settings by the people who live there, but also scalable. And that was the sort of distribution problem, an engineering, literally, problem that getting clean water was facing, that we also have to start thinking about, well, distributing mental health also has to tackle with those kinds of problems. And piggyback on other solutions. The movement to really reach a goal, not quite a billion, but 1 million community health workers. The primary care world has more modest goals than mental health world. But to piggyback on imaginative solutions, to imaginative other design solutions in the healthcare system, and imaginative other ways of looking at the breadth of the problem so you can address it. Other ways of looking at the community, of using crowdsourcing and other ground-up data about where hotspots are in terms of a condition of interest or behavior of interest, violent events, of looking at people who you are taking care of, how they're doing, and imagining how to do that in different ways. So I started looking at how are other areas of health or solving water problems or other problems who had to use scaled down technology to have scaled up solutions. How are they doing that? And how could we use those ideas to really meet this reach goal of 1 billion minds and lives, really scale up mental health and work out the working parts of the system to do that? And so one really strong idea that came out of that was to try to achieve modular design for mental health work. To think of what are the standard pieces of mental health work that are like letters of the alphabet. You have a couple letters of the alphabet, you can create 100 languages. Can we boil down, can we scale down sort of the key kinds of skill packages upon which you can build more complex and diversified mental health capacity? So we came up with 5. And so I don't know if you can see this so well, but the bottom is a sort of cluster of skills: case finding, engagement, follow-up, and psychoeducation. This is sort of a clustering of skills that share some similarity in terms of their technical complexity, in terms of what kind of person can learn this bundle of skills. And they also serve a critical function. In fact, this skill package, this functionality, is really what allows a system to really dig deep down at a neighborhood level, at a community level, where this burden of disease is really functioning, and tie the healthcare system to it, and as the people we're taking care of travel through it. A next level of targeted psychological interventions. That's sort of whatever brand of standard psychotherapy is your flavor of the month. All of them sort of overlap in terms of a kind of level of skill set and sophistication that can be managed. Medical management, both diagnostic and managing medications, is a separate skill set, supervision and quality oversight. And what we did in Haiti was to really, working with Partners in Health, was to really try to test drive this way of building up a system. And so what we did is we took each of these skill packages as a color, and we went down even further and really concretely said, okay, well, in this context, to apply a treatment guideline, in this case, the WHO MHGAP treatment guideline for depression, if we wanted to live up to that guideline, what sorts of activities needed to happen that are supported by each of these skill sets, and how does that translate into actual knowledge needs and tasks that have to be done within each skill set? And then we looked at the top of who are the people that we have. Starting from left to right, we started with people who live in the community, to the one psychiatrist we had for 1.5 million people. And basically went down and filled in who was good at what. And when you start thinking that way, when you don't start with people, which mental health folks, 5 minutes left? Oh my God. When you start with, we often start with people and get paralyzed there. Who should do what? Rather than starting and trying to standardize, well, what should we do? Right? And if you start, though, with what you should do, you realize you have lots of options and lots of flexibility and lots of adaptability in who can do what, and thus lots of actionability in what you can do. And there's actually, this is really a global conversation about how to modularize and get to the essence of the active agents of different kinds of mental health treatments. This is work in Boston by John Weiss and colleagues, and in looking across psychotherapies, what are the key sort of tasks and skills that really distill out of all of these that we can focus on those, and thus let people adapt them to different conditions and situations. And once you sort of map that out, you can take a care pathway, a care guideline, and turn it into a functional pathway that really translates good care steps into actions that people take in a sequence and a map that's pretty clearly laid out. And it lets you use a diversified workforce because they're interrelating in a logical way based on how you built up the system. And we're trying to use this logic to actually build up a system in the Partners in Health catchment area in central Haiti. And because we're starting with a modular design, with a replicable start of building parts, that makes it scalable. you can't scale up what's not scalable. So you have to start from a design point of view to both have broad reach and depth, but with pieces that can be scalable, which is why we started with this idea of modular design. So I've rehearsed this so many times. Every time I talk, I always talk over. So I'm going to apologize and rush through the last parts here. But so that's design, thinking in a standardized way for broad reach and depth. Knowledge. The previous slide talked about this idea, why most published research findings are false, which is a little bit of a provocative title, but actually points out a very important point, which is that a lot of the knowledge base that we need to apply at the ground level, while it is maybe methodologically very rigorous, still works with a specific context. So that when you go to apply it in different contexts, and the further the context you apply it in is different from where the original research was applied, you're going to not live up to and get the same outcomes. Whether it's a certain treatment or a certain way of organizing your work, whatever it was that was studied, as you apply it in different ways, you're going to diverge more from the outcome you're looking for. And so the point is not to do more research to understand why are we getting these different results, but to try to give tools to the healthcare implementers that are trying to apply this knowledge. Why are we getting different results? That's very interesting. Where is that variation coming from? And so in real time, there's knowledge creation about what needs to happen to implement. What are the factors that affect that context to apply global knowledge? And that's really the inside of the field of quality improvement, of continuous quality improvement, which is the idea that local agents can create theories as to why their particular context is or is not working to achieve results, and test those hypotheses rapidly without formal research design. This comes from work by the Institute of Healthcare Improvement, which really led the way in bringing those quality improvement methods into healthcare in the US, and is now starting to do that in low-income countries. And they're working in Ghana, for example, around improving infant mortality outcomes. And they've shown that you can give these quality improvement tools to local health systems, and you can reduce infant mortality rates. Not by adding doctors and nurses, but by giving implementers the tools to understand their own bottlenecks, to create ideas about their own solutions for implementation in a structured way, but really in their own hypothesis testing way. And a key step in that process is something called generating your own theory of change, or a driver diagram. And what it starts with is a goal, reducing under 5 mortality by a certain amount. And then locally thinking, well, what has to happen to achieve that goal? What's a primary driver to get there? And then what are all the other secondary drivers that are about process, that are about structure, that are about training, that are about workflows that you need to get there? And so what can we try to test and do that can make those things happen? And then all of these things become mini experiments. Let's try this. Did it have the effect we expected? Oh, that worked. That's a keeper. Let's do that. And when you have lots of facilities, lots of people working on the same broad aim at the same time, generating these hypotheses and doing these rapid experiments on their own, and coming together to share what they learned in doing this around that shared target that they're all trying to achieve, you actually bring these clusters of theories and hypotheses together and can generate huge amounts of knowledge. There's some money being spent now, for example, in global mental health around this idea of what's effective task shifting. Can nurses do this better than some other kind of work, or what kind of skills can be done by which provider? And to me, those aren't research questions. Those are implementation questions. Those are quality improvement questions. Those are the kind of questions that in a much more accelerated way can be addressed by these sorts of methods. And this is, in fact, a much more empowering way, because it gives sustained capacity built-in tools for managers to implement anything and adapt anything. I'm finishing up. And in fact, in low and middle income settings, these sorts of tools have been applied to successfully implement all sorts of healthcare change goals and improvement. So what I'm on the path of doing is to create an NGO called A Billion Minds and Lives, where the purpose is to make available in an open source and open access web-based format a really virtual workspace where groups can together do this kind of activity collaboratively, can have accessible to them these sort of quality improvement tools, a place to post and share their data and really learn together, but also a place, therefore, to store and harvest what that learning is on questions that are of interest very broadly. And so while I am leaving now, I promise, I need to acknowledge a lot of the folks that I work with, particularly in Partners in Health, and a lot of people who have given me money over the years. This is the psychosocial team at Partners in Health. But I do need to say that for all my technology savvy, I've never sent a tweet. So I just opened a Twitter account at @1BillionMinds, and the first tweet I'm going to send is a picture of all of you guys. And all I know how to do is to take a picture at this time. So before you leave, I will tweet you all. And so look for it, and I need a suggestion for a hashtag. Anything? Okay, I'll take a look at it. Thank you very much.